Hello, my name is Caitlin Jones. I'm a certified nurse midwife and women's health nurse practitioner, and today I will be chatting with you guys about substance use disorder and the postpartum period, also known as the fourth trimester. Before we start, I'm recording from Salt Lake City today, and I want to acknowledge the Shoshone, Paiute, Goshute, and Ute tribes, the original people of the land in which Salt Lake City stands. Additionally, this presentation is funded by the Utah Division of Substance Abuse and Mental Health, and I am getting compensated in my effort to create and provide this presentation. I have no conflicts of interest. Additionally, through my talk, you may see or hear substance use disorder and SUD, or opioid use disorder and OUD, used interchangeably. And when I refer to OUD medication, I am referring to methadone, buprenorphine, and buprenorphine naloxone combination drug. Before we get into the weeds of the fourth trimester and the content of my presentation, I want to review two guiding principles for caring for people with substance use disorder. First of all, substance use disorder is a chronic, treatable illness, not a moral failing. Substance use disorder is one of the most stigmatized illnesses in the world, and stigma impacts not only the way the general population thinks about addiction, but stigma impacts the way providers think about this condition and treat this condition, the way patients understand their own condition, and even the way recovery communities respond to treating this condition. One small change I challenge anyone listening to this presentation is to change the way you speak about substance use disorder and the language you use. Use of non-stigmatizing language honors the integrity of people experiencing substance use disorder, acknowledges substance use disorder as a disease process similar to other chronic diseases, and impacts the desire of patients to continue treatment, engage with their treatment, and engage in self-advocacy. I have included this table as a reference for your further consideration. It serves as a good reminder to me as well. Evidence supports that using this language actually improves patient outcomes by altering the way providers care for their patients. Thank you. Our second guiding principle is that people with substance use disorder have the right to bodily autonomy and to make informed decisions about their health care. This requires us to keep our biases in check, avoid making choices for our patients and clients that we think is best, and provide comprehensive and complete counseling regarding their healthcare decisions. An incredibly useful framework for counseling in this way is called shared decision-making. Shared decision-making is an approach in which clinicians and patients make decisions together, using the best available evidence to deliberate about the likely benefits and harms where patients are supported and arrive at informed preferences. Throughout this presentation, I will be encouraging the adoption of this framework when discussing healthcare choices specific to the fourth trimester with patients. Using this model holds us as practitioners accountable to 1, giving accurate, comprehensive, evidence-based recommendations, and 2, actively seeking understanding of patients' personal goals, priorities, and value judgments regarding their care. There is an excellent presentation on shared decision-making by one of University of Utah's own residents that I have included in your resource packet. Now, on to it. During this presentation, I will define the fourth trimester, discuss unique considerations and recommendations regarding SUD treatment during the fourth trimester, discuss unique considerations for patients with SUD who are postpartum in regards to breastfeeding, contraceptive counseling, and mental health. Finally, I will provide both a summary of my recommendations and a resource guide to connect you with resources I discussed during this presentation. The fourth trimester is the period of time from birth through the first year postpartum. Traditionally, postpartum has been considered the first 6 weeks or even 3 months after giving birth. However, in recent years and growing evidence of a longer transition during the first year and the unique risks during this time have changed the way we think about this. For postpartum patients with substance use disorder, an unfortunate irony exists that there is a dramatic increased need for support, but a decreased number of visits or points of contact with the healthcare system. Stress can reach critical points with increased financial demands, parenting, sleep deprivation, coping with adoption, coping with child removal, all within the context of an increased risk for limited social support. Risk for perinatal mood disorders, return to use, relapse, and death related to substance use increase dramatically during the 4th trimester. Excellent postpartum care starts with excellent prenatal care. Postpartum considerations are ideally addressed before birth, with a clear, patient-driven plan discussed before birth regarding their recovery, SUD treatment, mental health, resource navigation, parenting plan, infant feeding, and contraception. Next, I will discuss the unique considerations and recommendations regarding SUD treatment during the 4th trimester. As mentioned previously, women with SUD have an increased risk for return to use, relapse, and drug-related death during the postpartum time period. Strategies to address the period of increased risk is to maintain or even increase support and services. Complete a comprehensive postpartum assessment as soon as possible after delivery. Maintain regular visits with all team members, including the provider prescribing medication for opioid use disorder, if applicable, the OB provider, social work, pediatrician, mental health provider, both a therapist and prescriber of psychiatric medications, and peer support person. And ideally, provide this care through team-based care with clear communication among members. If you are already providing care within an interdisciplinary team, I recommend obtaining permission with your patient by having them complete a release of information form from patients at the time they establish care and continue to reassess as the number of team members they connect with increases. For patients receiving medication for opioid use disorder, the recommendation is to continue their medication through the postpartum time period. In my personal experience, many postpartum patients come to their first visit wanting to taper off their medication for opioid use disorder. Every effort should be made to avoid discontinuing pharmacotherapy for OUD through education of patients. SAMHSA strongly recommends continuing medication as long as patient is breastfeeding and ideally until the patient and child are well bonded and have a safe, stable environment and home. Taking this guidance into consideration, my personal recommendation is usually to recommend continuing at least the first year postpartum, if not longer. When providing counseling to patients regarding continuing their OUD medication postpartum, I advise sharing with patients that we know that both successful abstinence from substances and survival rate are higher at 1 year postpartum when pharmacotherapy is continued. Women in the postpartum period may need a dose adjustment of their medication. It is common for women to present with symptoms of oversedation. A dose effective in pregnancy may be too high during the postpartum time period. Also, women may present with increased cravings or return to use. This may indicate a need for a dosage increase, but should also prompt an assessment of engagement in behavioral support services. Please discuss harm reduction strategies with all patients currently using a NOT. Harm reduction strategies are practical ideas aimed at reducing negative consequences associated with drug use. The recommendation of these strategies is based on the belief in and respect for the rights of people who use drugs. Harm reduction services include drug poisoning prevention, such as providing naloxone, which is a complete opioid antagonist which knocks opioid agonists and partial agonists off their receptors and treats opioid poisoning, and fentanyl test strips, which empowers patients to test their drugs for presence of fentanyl, which unknowing consumption increases risk for deaths with use. Naloxone can be obtained through any pharmacy, but also an organization in Utah called Next Distro, which I will include in your resource handout, will mail naloxone to anyone in Utah who needs it for free. Additional harm reduction services include syringe exchange services in which sterile needles are exchanged for used ones, and supervised consumption services where people can consume substances with the presence of trained professionals to reduce their risk for death, not providing the substances. Of note, there are no sites that provide consumptive services in the United States currently. We know that harm reduction services do not increase use, but they do decrease mortality of this disease and exposure to infectious diseases. I acknowledge that many communities, particularly smaller or rural communities, do not have ready access to these services. I believe part of providing this care is advocating for the services you need in your community. In review, my recommendations are the following regarding substance use disorder treatment postpartum. Educate patients on increased risk for return to use, drug poisoning, and death during the postpartum time period. Increase points of contact with team members taking care of the patient postpartum, and fill out appropriate paperwork ahead of time. Do not discontinue OUD medication postpartum, and continue at least until social and home environment is stable. Offer harm reduction services to everyone. Next, I will discuss the unique considerations for patients with SUD who are postpartum in regards to breastfeeding. When discussing infant feeding, I encourage you to discuss infant feeding like any healthcare choice and provide all options and discuss the risks, benefits, and safety of each option. Infant feeding is a neutral term that acknowledges that there are multiple choices in regards to feeding an infant that include breastfeeding, pumping and bottle feeding, and formula bottle feeding. I think a lot comes up for us as team members who care for patients with substance use disorder in regard to breastfeeding. When counseling patients, it's important to check your bias, assess safety and risk, and make evidence-based recommendations to your patient or client. As a review for some, the American Academy of Pediatrics recommends exclusive breastfeeding for 6 months and with complementary foods for 1 year or longer. Infant health benefits include reduction in risk for asthma, obesity, type 1 diabetes, severe lower respiratory disease, ear infections, SIDS, and gastrointestinal infections. Medication that treats opioid use disorder, including buprenorphine products and methadone, are not contraindicated with breastfeeding. Levels of buprenorphine and methadone are very low in breast milk. And additionally, breastfeeding decreases the need for pharmacologic treatment for NOWs, which is discussed at length in a different training video. Contraindications to breastfeeding in the United States include HIV positive status and active substance use, including marijuana, but excluding tobacco use. While all patients should be counseled on tobacco and e-cigarette cessation, use of these substances is not considered a contraindication for breastfeeding. Here is a framework or guide in determining breastfeeding candidacy for women with substance use disorder. This is not a validated tool, but a guideline based on expert opinion. This is word for word based on a guideline in Tricia A. Wright's book, Opioid Use Disorder in Pregnancy, in the chapter by Jansen and Patrick. Many patients will fall outside these two categories and must be determined on a case-by-case basis. I encourage you to use this as a tool to counsel patients regarding safety of breastfeeding and the development of organization-specific guidelines and policies regarding breastfeeding with your local pediatrics team. An additional consideration is recommendations regarding breastfeeding and hepatitis C status. Positive hepatitis C status is considered safe while breastfeeding. There is no documented evidence that breastfeeding spreads hepatitis C. In the presence of cracked nipples, breastfeeding is not recommended until healing occurs. This adds to the importance of prioritizing support of postpartum patients who are hepatitis C positive who desire to breastfeed, to be connected with lactation expertise in order to reduce the risk for interruption of tissue integrity and then the disruption of breastfeeding for the infant. It is so important for all health workers, including social workers, to be knowledgeable and contribute to circulation of accurate information regarding safety of breastfeeding for women with substance use disorder. In review, my recommendations for patients with substance use disorder who are postpartum in regard to infant feeding is that every patient be provided comprehensive education regarding feeding options, to initiate this conversation earlier rather than later, to review safety of breastfeeding and pumping and feeding while taking medication for OUD, to review the safety of breastfeeding and pumping with all patients who are positive for HCV, to educate all patients that active use and HIV positive status are both contraindications to breastfeeding, and discuss strategies to prevent HIV and get into stable recovery as a means of avoiding these contraindications. Next, I will discuss unique considerations for patients with SUD who are postpartum in regards to contraceptive counseling. Like breastfeeding, contraceptive choices of patients with substance use disorder generally bring up some feelings for providers. Things to keep in mind in thinking about this part of patient care is that women with SUD have the right to make informed choices about their contraceptive options. We have an ethical responsibility to our patients to provide high-quality, comprehensive contraceptive counseling, which means discussing all contraceptive options a patient is eligible for, seeking understanding of patients' priorities for their contraceptive method, and avoiding engaging in reproductive coercion. In order to do this, it is important to keep your biases in check and also what you think the best method for a patient is in check. Keep in mind that women with SUD are more likely to experience unplanned pregnancy. Some patients with SUD may find it challenging to return for a future appointment after deciding which method they desire. So I recommend working to be able to counsel patients on immediate postpartum contraception and same-day initiation options. A bit here on reproductive coercion. Reproductive coercion is a behavior that interferes with another individual's sexual and reproductive health goals in order to assert power and control. This can occur from a patient's partner toward a patient, but also can occur from a provider toward a patient. Coercive contraceptive practices from a provider toward a patient can look like poor communication, failure to explore multiple options, demonstrating resistance to a patient's preferred method based on a value judgment, and clinicians who impose a single method. In effort to avoid these behaviors, high-quality contraceptive counseling requires presenting multiple options, asking open-ended questions, active listening, using written materials and visual aids, and honoring a patient's preferences. In order to counsel patients on the safety of an option, I recommend using the CDC's medical eligibility criteria for contraceptive use, also called MEC. This resource includes recommendations for using specific contraceptive methods by women and men who have certain characteristics or medical conditions to assist healthcare providers when counseling patients about contraceptive choices. It also can be downloaded as a free app. A few comorbidities to consider for women with SUD. Both smoking or hepatitis or cirrhosis with severe liver decompensation are contraindications for methods that contain estrogen. In regard to mental health treatment, some antipsychotics decrease the efficacy of oral birth control pills. For HIV-positive patients, some birth control methods may interact with their HIV medications. HIV is not a contraindication for an IUD, and antibiotics are not considered necessary with or after placement. You can refer to CDC and this app for more in-depth information regarding risk and these comorbidities to empower your counseling with patients. Visual aids are an incredible tool to integrate into contraceptive counseling, as they aid the provider in providing comprehensive counseling and providing multiple options, and aid the patient in understanding their options and asking follow-up questions. UCSF has created excellent visual aids for this purpose, which can be ordered for free through their website, which I will include in your resource sheet. I urge everyone who provides contraceptive counseling to include emergency contraceptive methods in counseling any methods that might be impacted by user failure. These methods include Plan B, Ella, copper IUD, and recently, there is impressive evidence that the LNG IUD is equally effective as the copper IUD in preventing pregnancy. I will include the information to access this article in your handout. Please include in all counseling that Plan B and Ella only work if a patient has not ovulated yet, and review the patient's likely ovulation window. Additionally, please include in your counseling that Plan B is not considered effective in patients with BMI over 30, and Ella is not considered effective in patients with BMI over 35. And it is important for patients to know this when making their healthcare choices. The visual aid on the left can also be obtained for free through UCSF's website. I highly recommend offering long-acting reversible contraception options immediately postpartum for patients who desire one of these methods. IUDs can be safely inserted within 10 minutes of delivery. Many providers pause in providing this because risk for expulsion may be as high as 10 to 27%. However, even with increased rates of expulsion, rates of continued IUD use at 6 months is higher in patients with immediate placement when compared to patients who plan on placement at 6 weeks. This option is contraindicated in the setting of III and postpartum hemorrhage. Additionally, the hormonal implant can be offered before discharge. There's a theoretical concern for disruption of breast milk coming in, but this has yet to be supported by evidence. In review, my recommendations for patients with SUD who are postpartum in regards to contraceptive counseling is to provide comprehensive counseling using visual aids, asking open-ended questions, and find out what patients' priorities are regarding their method of contraception. To use evidence-based resources to evaluate the impact of comorbidities on contraception eligibility for each individual patient. To provide counseling on emergency contraception for every patient who elects for a user-based method. To provide counseling on and offer immediate postpartum contraceptive options. To be prepared to provide same-day contraception initiation for all contraceptive options postpartum. And to check your bias regarding contraceptive choices for patients with SUD, and honor and respect patients' decisions regarding their own reproductive health care. Next, I will mention a few considerations for patients with SUD who are postpartum in regards to mental health. The need of access to evidence-based, high-quality mental health care for this patient population cannot be overstated. For my licensing and area of expertise, this presentation cannot and will not provide sufficient training on the comprehensive management of postpartum mental health care for patients with substance use disorder. Please do not mistake the brevity of the content during this portion of my presentation with its importance in the postpartum time period. From experience, mental health care and psychiatric care are the mainstay of postpartum care in this population. Please keep in mind, women with SUD are more vulnerable to develop perinatal mood disorders or experience worsening status of existing psychiatric conditions. Women with SUD and co-occurring mood disorders are at risk for return to use and discontinuation of pharmacotherapy for OUD. Women with SUD are more likely to experience emotional, physical, and sexual violence, have unstable housing, do not have access to reliable transportation, and experience financial stressors. At the first point of contact postpartum, please complete a comprehensive mental health screening for all patients, including screening, rescreening for substance use, perinatal depression, anxiety, mood disorders, and intimate partner violence. All the screenings mentioned above are validated tools. The gold standard of treatment for perinatal depression is both cognitive behavioral therapy and medication. All providers should work to become familiar with first-line therapies for depression and anxiety, particularly SSRIs, which are overwhelmingly considered safe with lactation. For discussing safety of particular medications during lactation, I recommend referring to an excellent resource called Mother to Baby, which has created evidence-based handouts for medications during lactation and pregnancy. A special consideration should be made for patients who either have been diagnosed with bipolar disorder previously or have positive screening for bipolar disorder with an MDQ screening. Women with SUD are often diagnosed with bipolar disorder during periods of substance use, which can contribute to the presentation of symptoms. Additionally, patients with bipolar disorder are more likely to experience postpartum psychosis and experience exacerbation of symptoms with common antidepressant medications. Ideally, these patients should be evaluated by someone trained in psychiatry and closely followed for response to treatment. Women with SUD are more likely to experience housing insecurity, food insecurity, interpersonal violence, and social isolation. When these needs go unmet, it increases risk for return to use and death related to substance use postpartum. Additionally, it increases risk for presence of exacerbation of psychiatric comorbidities, including perinatal mood disorders, and decreases the likelihood a patient will maintain their right to parent their own children. Addressing these needs is paramount, and integrating team members with expertise in case management and resource management and social work is crucial for the health, safety, and well-being of postpartum patients. At the bottom of the slide is a list of needs that should be addressed postpartum. I highly advise having resources prepared to address these needs as they present postpartum, or again, having integrated expertise in the team caring for this population. In review, recommendations for patients with SUD who are postpartum in regards to mental health care is: discuss with all patients their risk for perinatal mood disorders, signs and symptoms, and possible treatment options. Perform or repeat comprehensive mental health assessment and social needs assessment postpartum. Be prepared to initiate treatment for perinatal depression and refer or consult if a patient's presentation is outside your current scope of practice or comfort level. And to the greatest extent possible, integrate social work services into postpartum care. If unable, curate a list of referrals and resources for when needs are identified. Thank you for your attention today. I hope you found this training module to be supportive to your learning in caring for this population, and my recommendations and resources will provide you with a practical foundation and confidence in providing this care.